Are we seeing a spike in emergency room visits? Are you all keeping track of that information?
We'll know that through the evaluation. I don't have systematic knowledge across the state for any hospital now.
We don't, is there a monitoring system to tell us that? So the data, other than the data from claims, and let me just say that what we are able to look at currently is any spending related to a new eligible, the expansion group. It comes through our insurance claims system, in the MIS, the thing that's being procured. Those include just the medically frail and those who are in the enrollment process. For those who have a private insurance card, we don't have any of that data yet and don't expect to have that data, which we call it encounter data, just to distinguish the fact that we're not the ones paying the claims, it's the private carriers that are. We will get that data about this time next year under the terms of our memorandum of understanding with the carriers, and that's what it'll take for us to do more of a comprehensive or inclusive look at emergency room use and other healthcare use.
Right, well, I'd like to see it with private insurance, but I'd also like to see it too, like you said, under the temporary, because there are temporary, or we see a spike. People getting these cards, they can't find a doctor because of maybe the confusion or whatever, so they're just automatically going to emergency room. So I'd kind of like to see that data once you guys get it. I guess my last question or minor question is, the last figure that we've got is that the private options costing an average of $483 a month. Number one, has that number gone up? And my second question is why has it gone up over the original estimate of 437? And I think the figure we got in December and January was 467, jumped to 483. Has that number gone up? Why has it gone up?
So yes, the number is slightly above the target that I referred to earlier, which is in the waiver terms and conditions. It wasn't in January, it was in February, March, and it will be again in April. And it's a combination of two things, both of which were subject to prediction back in October and November and December. One is the age distribution of enrollees, which has turned out to be slightly higher than predicted, still much lower than the rest of the marketplace, making Arkansas's marketplace easily the youngest in the country, other than DC, but they only have a few thousand participants to account. And yet still a little bit older than we had predicted. And in March and April will be a little bit older than they were in January. Also plan choice, to some extent, drives for auto selection or assignment of the health plan within the marketplace for those who are in the private option affects those averages. And so the actuaries made a prediction. They implicitly had to make two kinds of predictions. One, age, and two, which health plans would individuals select. And that turned out to be it's slightly different also than predicted, and slightly different in January. Clearly, some individuals, we're talking about percent here, selecting slightly more expensive health plans. This goes back to the introductory remarks that I offered earlier. Some of the reason that those health plans are more expensive is that they include benefits that we didn't anticipate paying for. This was really a function of the simultaneous review of health plans by the combination of both AID and the federal government last year, and the development and completion of our waiver and acceptance of it. We more or less found out at the same time what our terms and conditions agreement was, and then what the benefits that were actually offered in the health plan would be. It's okay, we're not violating the terms and conditions, but we are paying for some benefits we didn't anticipate paying for. That we can correct in years 2 and 3 of the waiver. So I think it's a combination. We're about a half year older than we were in January, and the mix of carrier assignment choice, percent swing on the health plan side.
I just want to be real clear. The terms and conditions recognize those two estimates and have mitigation strategies that are exercisable by the state should those things be issues. So there's not even exposure to
No,
the state.
we have so many more months of coverage in 2015 and 16 that good management, good decisions following through with this transition to market. I don't anticipate any problem at all. Waiting really good experience and numbers in 2015 and 16 with the first few months or the first year, for example. And that's, again, the transition to market is important here. First, we need competitors. Then we can drive price-sensitive purchasing through competition. One comes before the other. So I referred to that swing in more or less market share across carriers. It does affect the average premium payment. By the way, the carrier with the higher premium payment is new. So part of our strategy is to build competition by creating a market for a new entrant.
All right.
So these things work together, and we expect that transition will